So, as most of you know, I'm a licensed psychologist. I've worked in the MAT field since 1995. I also work a lot with people with substance use disorders and suicidal ideation or past suicide attempts, including last night. I think I did 3 safety plans, either revised 2 and then created 1 for patients I was seeing last night. So something I do quite a bit of. These are our continuing education learning objectives. Um, these are the objectives for today. I did do this presentation on here about a year ago, and I updated it because there's actually a bit a bit more research on the topic. So we'll look at some of the suicide rate data for opioid use population, look at some crisis intervention steps that have been promoted for a variety of healthcare settings. I'll look at a safety plan, and I'll show you an example, and we'll also send you out a PDF of a safety plan, as well as, oh my God, it's the Columbia Suicide Prevention Center. I think that's the name of it, but you'll see it in a moment. They provided some interesting PDFs to provide to family members of people you're concerned about. So that's something to think about as well. So if you have relationships with your patients, significant others who are about promoting their recovery and want what's best for them, they can also be an ally in helping to prevent suicide. So we'll kind of look at those things. And I did just want to, I had a link at the very end too for Question, Persuade, Refer, which is a suicide prevention training. We do it with the medical students and the pharmacy students at NEOMED. It's been promoted in a variety of healthcare settings. And essentially the idea behind all of that is that we also need to look out for one another. Probably some of you on here have had colleagues who've died by suicide. I have. It's kind of weird. I feel like I can ask patients about suicide all day long, but with colleagues, I get already like emotional talking about it. With colleagues, it's harder for whatever reason, even if I'm concerned. So, anyways, there are resources out there, and we'll certainly pick up on some of those topics as we have in the past. But this is going to be more patient focused today. So, a few definitions. Crisis, a stressful, my goodness, crisis, a stressful life event that overwhelms a person's ability to cope effectively. And, you know, many of you talk about how even COVID-19 or other issues have kind of been this stressful life event. So you had patients who were doing pretty well in their recovery, but then all of a sudden, perhaps they're concerned about family members or themselves, or they don't have access to their support groups anymore. And just these, maybe they've lost their employment. And it sort of overwhelms what was typically working for them, right? So it overwhelms the system. Crisis intervention is an immediate short-term help to individuals who experience one of these crisis events. And then a safety plan is a written list of coping strategies and sources to support patients during or before the crisis. And it has been demonstrated to be a best practice in primary care and other related clinical settings. And like I say, we'll show an example at the end of this. So this is, I think, really important to keep in mind. Suicide's a hard behavior to study. First of all, it's hard to even know whether an event was a suicide or not. So this is a New England Journal of Medicine article that got quite a lot of publicity in 2018. Basically they argue that we know that there's a number of overdoses from opioids. What we don't know is whether they're intentional or unintentional. And they argue that likely more of these events were intentional than what we've categorized them as. That's nothing new. People always struggled. You know, an automobile accident, you got one person who hit a tree without their seatbelt on. You know, was that a suicide or was it an accident? So it's always a hard issue to study for many reasons, that just being one. So let's look at just some suicide rate information. So specific to Ohio, this got quite a bit of publicity in Ohio as well. Suicide deaths increased by 45% among all Ohioans and by 56% 10 to 24 from 2007 to 2018. Which is why there's the Ohio Mental Health and Addiction Services has a state level suicide prevention plan that really is focusing on that 10 to 24 age group, but also for others as well. And then this was a 2015 study. They were looking at about 2,200 patients who had made suicide attempts between 2009 and 2011. And what they did was they kind of looked to see if there had been any healthcare visits before the attempt. And overall, they found that 38% made some type of healthcare visit within a week before attempting suicide. A visit came within if you looked at it from a month before the suicide attempt, it was up to 64%. And when you looked at it at a year, it was 95%. And percentage of visits with mental health or substance use disorder, so patients with those issues, was about 25% within a week, 44% within a month, and 73% within a year. And this part of this data kind of began to, at least in the literature, started to argue that it was important to take sort of a zero suicide perspective, where we all of us in the healthcare system, but even teachers, people who interact with people, need to be thinking about suicide and having skills to assess and then refer people to appropriate treatment. So now we'll look a little bit more at opioid use disorder and suicide rates more specifically. So this is a 2017 study where they controlled statistically controlled for overall health and psychiatric conditions. This is also a nationally representative cross-sectional study with about 4,100 people. And they found that prescription opioid misuse was associated with anywhere between a 40 and 60% increased risk for thoughts of suicide, so suicidal ideation. A little bit more, this is a 2019 study. They kind of looked at three groups. So they looked at opioid use, people who used opioids, people who misused opioids, and people who didn't use opioids at all. And they looked at the associations in those three groups with suicidal ideation, suicide plans, or suicide attempts. And it was adults 18 to 64. It's about 86,000 people. It was part of the National Survey on Drug Use and Health. It was collected in 2015, 2016. So they found that compared with opioid misuse, opioid use was associated with lower odds of suicidal ideation, so odds ratio of 0.57. Suicide plans, 0.53 odds ratio, and suicide attempt, 0.71 odds ratio. And then the no-use group, I shouldn't say not surprisingly, but no-use group is associated with lower odds of suicidal ideation as well in comparison to the misuse group. So odds ratio of 0.62 for suicidal ideation, suicide plan, odds ratio of 0.56, and suicide attempts, an odds ratio of 0.54. And then, okay, this is, so I guess the first part of that is just to suggest that probably what you all know, that the folks that we're working with, people with opioid use disorders, are at a higher risk for different types of suicidal behaviors. This is not meant to be any recommendations, but I always like to be, kind of comprehensive. And when I do searches on suicide and buprenorphine, interesting things come up. So this is a 2016 study. I think this kind of gets to Christos Reyes kappa agonist depression, perhaps, discussion earlier this morning with buprenorphine and depression. But reported that patients who received an ultra low dose of buprenorphine, so you see 0.1 milligram once or twice daily, getting up to about 0.44 milligrams a day, had a greater reduction in the Beck Suicide Ideation Scale score than patients who received a placebo, both after 2 weeks. And there's a significant difference between those two groups. And this is another kind of on the other extreme in terms of dosage. This is a 2018 study where they randomly assigned male patients who were hospitalized for suicidal ideation and had opioid use disorders to a psychiatric inpatient ward for 2 days. And they gave them 32, 64, or 96 milligrams of buprenorphine in one single high dose. And they reported a significant decrease in suicide assessment scores across all of those groups, so each one of those doses, and no between group differences. So they were all the same. So again, this isn't a recommendation that if your patient's suicidal, just give them buprenorphine. It's just so you have the information. So lastly, like I mentioned, It's really challenging to determine whether or not a overdose was intentional or unintentional. So this is kind of a nice study, a 2018 study, where they looked at all-cause mortality. So that could be anything from what was known as a suicide to what was known as an overdose to traffic accidents to whatever. And there's a meta-analysis. So they looked at 21 studies of all-cause mortality rates. And they found that for patients who were engaged in Suboxone, 0.93 per 100 had some kind of all-cause mortality death. 0.26 per 100 while engaged in extended release naltrexone treatment, and 4.89 per 100 for an untreated period. So that's pretty substantial in terms of folks. And the untreated period really meant it was someone who had been engaged in either Suboxone or naltrexone treatment, and then had a period where they were not being treated. So they discontinued or discharged for whatever reason. And then specifically to overdose, which is obviously more narrow than all-cause mortality rates. So they looked at 16 studies, 0.24 per 100 while engaged in MAT altogether. So that's bundling together buprenorphine and naltrexone, and 2.43 per 100 for the untreated period, which is why I always say to you all, thank you so much for the hard work that you do, because it makes a difference in people's life. It gives people another opportunity to make decisions that are going to help them and their families. So very much appreciate that. So suicide and MAT. So like we mentioned, patients seeking opioid use disorder are more likely to, well, they're at increased risk for suicide. And that's also in part because they are more likely to have chronic pain, which is known to be a risk factor for suicide, and or a mood disorder. People who relapse on substances are at an increased risk of suicide. That's a pretty well substantiated risk factor. I've certainly known people who've died by suicide after relapsing. It can be incredibly painful for those folks, and they just, I guess at that point, lose hope. There's an argument that screening should be done for suicide risk regularly in settings in which opiates, but also, well, buprenorphine is an opiate, but where basically opioid use disorder treatment occurs. And standardized screening as well for suicide risk in all settings. And for ED patients who overdosed, an attempt to really try and refer them to an outside provider. So obviously there's some things you can use, like your validated screening and assessment tools. The PHQ-9, the Patient Health Questionnaire 9, is something that people oftentimes use. And there's also the Ask Suicide Screening questions, which are briefer. You have the resources there. Some EMRs come with built-in suicide screening tools, kind of ticklers to remind you to do it periodically. There are also evidence-based treatments that target suicidality specifically. One of the ones that is pretty interesting and has a lot of empirical support is the Collaborative Assessment and Management of Suicidality. So you would likely be referring to someone who was trained in CAMS. What's interesting about CAMS is it's a psychosocial treatment, but it looks at, it addresses suicide specifically. So not necessarily depression or other issues that might be a contributing factor to suicide, but it really targets suicide specifically. And the rationale is that there's some people who die by suicide who maybe they were depressed, or maybe they had, other mental health disorders, but they had never been diagnosed and had never been in the system. So I don't know that we necessarily know for sure that mood disorders or psychiatric symptoms are always a contributing factor to suicide. And then there's brief interventions, which we'll go through in a moment. I always give patients that I'm working with, as part of my informed consent process, I give them the National Suicide Prevention Lifeline number. I give them the crisis text line number, text 4 to HOPE. That's specific to Ohio. They could just use 741 as well. But what's nice about when they text for HOPE is that they collect data on calls and times of year about Ohio specifically. And we look through that for our Ohio higher education initiatives pretty regularly to see what's happening. safety plans or crisis response plans, reduced access to lethal means, and then obviously in the involuntary hospitalization, or what we call the pink slip. So the 6-step crisis intervention model, I'm just going to run through this, is helping the person, first of all, define what the problem is from their point of view. What is the issue? So an example might be, which I know I've heard a few people talk about this, and I've experienced it. We have a patient and their sponsor relapses and dies of an overdose. That can be the crisis, right? And it's overwhelming to people. And so that's the crisis. But the problem may be that now your patient has a sense of hopelessness. Well, if this person couldn't do it, then how on earth could I? Ensuring patient safety as best you can, assessing imminent risk. So asking close-ended questions like, are you thinking about killing yourself? Do you intend to kill yourself? How do you plan to kill yourself? Obviously, that gets at the things we think about with ideation, suicidal ideation. Are you thinking? Intent, do you intend to kill yourself? And then plan, which are kind of like the 3 factors that you do when you're doing a suicide assessment: ideation, intent, plan. Provide support, really communicating that you're concerned about them. If you practice like this, to say that you care about them, and that you're willing, or perhaps you have to tell them you're mandated to help. Affirm their strengths, let them know what you notice in them. That can go a long way. Examining alternatives. So if a person's reporting they're at imminent risk to kill themselves, or obviously others, but we're focusing on suicide, then you're at that point probably not going to be examining alternatives. You're going to be working to get them into the hospital. But if it's a step down from there, you can explore any options they have to help manage the crisis, help them identify people who may help them or provide support, talk with them about different coping strategies, things that worked in the past. Make a safety plan. Again, you wouldn't be using a safety plan for someone who's at imminent risk to seriously harm self or others. Again, you'd be looking at a hospitalization at that point. We'll go through the safety plan really briefly, an example, but it's meant to be individual and collaborative, right? Like for one person, what's a coping strategy isn't for another. You focus on existing social support, but you also put numbers in there for 24-hour backup. The idea is you want the people to have one sheet of paper that they can see everything, because we all know when you're in crisis and you're emotionally aroused, it's hard to remember things like, what's that number and where do I go? Include one or more reasons the patient has identified for living. We call that protective factors. So what's a reason why you wouldn't kill yourself? How come you haven't killed yourself already? It's not uncommon for people to say things like, it's incongruent with my religious values, I'm scared to go to hell, or I couldn't do that to my family, whatever it is. Sometimes it's pets, whatever it may be. Plans should provide patient with positive action steps, those things that they can do. If they're reaching out to their sponsor, reaching out to a trusted friend, going over to their mother's house, and it should be congruent with their goals and values and just their level of functioning. So there's a link right there, the Suicide Prevention Resource Center. And by the way, there's a lot of information there, but they have a lot of different examples of safety plan templates that are free, and lots of other resources. I just did want to mention, there used to be these no harm contracts, and the shift was then to safety plans. A no harm contract was basically saying, I promise Dr. Russell, I will not kill myself. And the research suggested that there really wasn't much effectiveness to that, probably for obvious reasons. They may, promising something to us may not be that important to them, whereas coming up with what might be ways that they could deal with the issue could be more helpful for them. And then lastly is just kind of good communication, just having the patient repeat back to you what the plan is. So that you're sure that they're understanding and that you're understanding and you're all on the same page. Lastly, I'm not going to go through this, but the Ohio Revised Code has the criteria for emergency hospitalization. So if you have to pink slip that person who doesn't want to go to hospitalization, and psychiatrists, psychologists, physicians, health officers, parole officers, police officers, and sheriffs can do pink slips in Ohio. This is just more criteria for the pink slip. I'm going to not go through that. After the pink slip though, or when you're in the process of, if you live in well, all counties in Ohio, pretty much all of them have crisis intervention team officers, CIT officers. They are specially trained to treat people who are having a mental health crisis. We encourage people, if they're calling to have a person involuntarily hospitalized, to ask for a CIT officer. They're going to have special training to do that in the most de-escalating and supportive way possible. And I've seen both types of police officers, and it's very different when you have a CIT officer involved. And obviously with the pink slip, what it does is it holds the person for 24 hours, and it gives time for them to be evaluated and determine whether they'll be admitted or not. This is the last thing I'm going to show you, the patient's significant others. Yes, the Columbia Suicide Severity Rating Scale. And it's essentially, I'll show it to you, but it's something that you can give to family members. This is significant others. They have a variety of different ones, but you can give to family members if you're concerned about a patient's risk for suicide, so that the family knows how to ask the questions and what to do. So those are resources there. Let me stop. Let me stop this for just a second. And then